What I can say about my experience in primary care medicine for 30 years is that knee problems were very common, first of all. It has been postulated that the lifetime risk of developing symptomatic knee osteoarthritis is about 40 to 45%. That indicates that during your lifetime you have about a 45% chance of developing significant knee osteoarthritis. In a primary care medical practice like mine, about 30% of the visits were due to musculoskeletal problems, and about a third of those were related to knee pain. The symptoms that we would see patients most often for would be pain, joint stiffness, impaired mobility, but some of the lesser ancillary symptoms that we didn't think about initially would be things like poor balance, poor sleeping, falls, mood disorders, and weight gain, all directly or indirectly related to knee osteoarthritis. The first question that I have would be, can you talk about the structure of the knee, in particular those structures of the knee that are most commonly involved with either injury or disease?
The World Health Organization has said over the next 20 years, the number of physically disabled individuals from osteoarthritis is going to double to about 50 million around the world. Not a small number. So this is a very, very significant threat. And my general sense is the more all of us understand how do these things we have work, how do the parts work. So a statement that I often say through my day is that if your body and your brain are a company, you are the CEOs. How do you want to manage your company? And so many of the problems that I see are years and decades in the making. And often I have to explain to somebody who has multiple medical issues, physical issues, hey, the knee pain that you had, that may have started a long, long time ago. So with that said, ultimately all of us have knees, but hopefully one of the concepts I want to put out there is our body is the most sophisticated piece of hardware that we will ever own. So the more you understand how it's supposed to work, the more that any proactive or treatment recommendation is going to register. So if we look at it simply, our knee has 4 bones. The femur, the tibia, the patella, and this thing called the fibula back here. But the important parts that are really relevant for what we're talking about are you have the thigh bone, and you have the leg bone, the tibia, and you have this kneecap. And if you look at them very carefully, you'll see that they are different shapes. And as we walk and as we move, the knee will actually bend. You're sitting in a chair, you're in a chair, you're getting up from a chair. Well, what are all these things in between? If you look at the knee from the side, it's round, convex, and it looks pretty flat here. But what's this thing in between? So we have these bones, and bones have nerves in a very dense distribution. So if all we had were bones on bones, then we'd be hurting all the time. Okay, remember that part. So what protects these from rubbing up against each other? Well, there are 3 structures. Number 1, it's this structure called a meniscus. All of us hear the word meniscus, and everybody has their own idea of what that means. The meniscus is basically about 3/4 of a donut. If you can imagine that I could sandwich a donut inside this joint, and now what that does is it acts as a buffer. And if you notice, it allows there to be an even load distribution. If you see, you're now making this flat bone at the bottom a little bit more concave. Can all of you see that? And so what that does is it disperses the load as we move around. Right? Now, the second part of that is, which we always say this is the gold of the knee, is this lining. And the lining of the knee, which is here and here, it's behind everything. It's what is connected between the kneecap here and the joint back here. If you can imagine a lubricated, bouncy ice skating rink, that is what normal cartilage looks like. And if all of you could go back to when you were 15 years old, that cartilage becomes like a new sponge that you just buy. You dip it in the water and you squeeze the water out. So every time you squat down, you squeeze the water out, and when you get back up, the water sucks back in. So the property of this lining, that's called articular cartilage, is a fantastic mechanical structure which holds water, and it uses that fluid as a way to act as a shock absorber as well. So the meniscus, number one, the cartilage, number two, and then the final part of it is you have to hold it all together. If I took a step and I left my leg behind me, that would be no fun, right? So ultimately, everything has to be held together. And so we have these ligaments, and ligaments are basically ropes that connect on the outside, on the inside, and they keep the knee from being unstable in that direction. And then there is a ligament in the inside front and the inside back, and that keeps it from going forward backwards. So when all of these parts are functioning well, then you have a happy knee.
What are the most common diseases of the knee and most common reasons for knee surgery?
That's a big question. So why don't we, to keep this in a certain context, the disease you mentioned earlier, osteoarthritis. Let's focus on that, because that is the top of the list. That's something all of us face. But there are a few things that I want to point out before we get to the surgical part, because I am a surgeon and I like operating, but I would probably say I convince more people not to have surgery. And the reason goes into why. Anytime you see a doctor, you want to ask them, why? What's the reason for this? And the statistics we have, even though none of you are a statistic, you're all individuals, we can use research and science on which to guide decision making. So if we look at the most common diseases, you mentioned it, osteoarthritis, a bunch of different words people use for that. And I don't know what it means to all of you. Very often if we mention the word arthritis, people go, oh my God, it's like cancer, right? Nobody likes to know I have arthritis. So I prefer descriptive terms. When we look at the word osteoarthritis, what that really means is, if you consider what I just said, there's a condition now where that fantastic structure that I mentioned, that has started to break down. Now the question is, why? Right? And many people before me have said, if you want to devise a solution, the first thing you want to do is understand the problem. If you don't know the problem, then you won't be able to devise a solution. So the question is, why do joints wear out? And I would say there's not one answer. Anybody who develops osteoarthritis, there are multiple factors. However, here are a few factors to consider. If I stand up straight, my knees and my ankles are touching, but in a bowed knee, my knees are going that way. I can't make my knees bowed. But if you consider that my center of gravity is going down the middle, then imagine if you could put a tire on the car and bend it this way, you're going to wear out there. So sometimes it's obvious. And nobody does something to make it bow. It's just the way we were born. But it sometimes takes decades and years of wear to develop a problem. The opposite is this way. We call that valgus or knock knee. Everyone has words for that too. So one of the causes of wearing out of the knees is just the alignment, the shape. Now, obviously injuries. Let's say you're 30, you fell down the stairs, broke your kneecap. We know that anytime someone has an injury, there is a cycle of events. The body tries to fix it. The immune system, right? We heard a lot about the immune system with COVID, right? Everyone knows what that word means. Our body is a sensing and signaling machine. And so once we fall down, that machine gets turned on. And all of these cells go around and try to fix it. One of the things that we've learned about that pathway of, we call it inflammation, was we had this idea that inflammation is bad. But inflammation is how the body gets everything done, as you know. And we used to think that inflammation goes up and then it comes down. What we're finding now is there are different cycles that people experience. So we will generally see, and I'm going to oversimplify. Let's say I fall down and hurt my knee 20 years ago. We know that a subset of people will have it heal and get better the rest of their life. They never look back. But there is another subset of people where that immune reaction will continue. In fact, not only does it continue, it continues to stimulate cells that are going to continue to damage the knee. And this ultimately will lead to post-traumatic osteoarthritis. So one of the causes of degeneration of the knee is later development of arthritis as a result of this inflammatory process that has become dysfunctional. And so if you notice, what this means is the immune system, which is supposed to take care of you, has done something wrong. It is misfired and is sending out these cells that are actually doing harm to the knee. One of the very exciting areas of technology that we're seeing now in the world of arthritis is the idea of identifying what's happening with the fluid in your knee and what can that tell us about what's going on. So it's this inflammatory, we call it a cascade, that sometimes comes up around the third or fourth month, right? Now, one of the most common reasons is, hey, we don't know. Someone comes in, let's just say they're 65, 70, 75. They say, I was doing fine. I go for a run, I play tennis, all of a sudden my knees started hurting, okay? So we can't always pinpoint exactly the why do these things happen. And so it turns out that that inflammatory process I was telling you about, that often is a part of it. And so I think the second question you asked is, what are the indications for surgery? And it's a hard one to answer because ultimately I look at what a doctor should do as being a bit like an investigator solving a mystery. And number one, as Dr. Dibble would agree to, it's all about the history and exam. Listen to the story. Did somebody have an injury? Did they not have an injury? What kind of role does exercise play in their lives? I often say the body and brain will do what you train it to do. And so we try to figure out what are those elements that go into what brought you here now. And then we look at the physical examination. Are the knees bent? Is there stiffness? What are the different characteristics of how somebody walking? And one of the big parts of it is function. How is someone functionally using their knee? Are they able to get good single leg control? I would say if you forget everything I'm going to say today, I want you to remember one thing. Your future, it has a lot to do with how are you on one leg. And what I mean by that is if you're standing and you're on one leg, whether it's this way or that, that's how you're doing when you're walking. And what ideally is supposed to happen is these muscles here are supposed to control your pelvis so that you are putting just the right amount of load here. As all of us age, one of the things that happens is we move our center of gravity forward. We lose control of some of these muscles here. Our back gets stiffer, our hips get stiffer. So when we start to walk, if you look at what I'm doing, our lives are just us against gravity. If I let go of my muscles, I'm going to drop on the ground. So my body is working right now. So what we really want to do is to turn that into efficiency. So when I examine someone, I look for how efficiently are they walking. Are they using all the muscles that are here? And you may ask, why does that even matter? Because when you're moving efficiently, you have less impact. If you have less impact, you usually have less pain. So while it would be very tempting as a surgeon to take somebody with some wearing of the knee and tell them all the fun things that we can do with joint replacement, as I'm going to show you, the risk of working on those muscles is zero. And the payoff is huge. If you're doing everything that you want in your life and you have no pain, you won't care how badly the doctor says your knee is worn. Yeah? Is there anyone who disagrees with that? And so that is why one of the first things we'll often recommend, and this may be a later question, so sorry I'm jumping forward here. One of the first things I recommend is talk to a therapist. Come up with a plan that makes a lot of sense. But the idea of a physical therapy program is, what is the body going to learn? If I take guitar lessons and I don't want to learn how to play the guitar, I can take 100 lessons I'm never going to learn. Why? Because I have to be committed. I have to say, I want to get better at it. And the way I look at it is, movement is a practicable skill. And what a therapist or a trainer or a coach or a YouTube or your friend or anyone can offer is to help cue somebody. What do you specifically need to work on? And I talk to therapists all the time about this. And I very often hear people say, I went to therapy 6 times, it didn't work. And I say, well, wait a second. Education is not about working or not working. There are a lot of factors to it. And one of the biggest ones that I hear is, and it's why I mentioned this idea of how are you maintaining your system. If I say activate your hamstring to rotate your pelvis, does everyone even know what that means? Does that make any sense at all? And just like learning how to swim, it's not something you can just talk about. You don't talk to someone about swimming. You put them in the water and you figure out what can they do. And then you modify it from there. Is that making sense? And so ultimately, when we're looking at the surgical indications, when do I recommend an operation? My formula that I use is that I don't have formulas. I sit down with somebody, we go over everything, we go over the story, the exam, I look at structural evidence, we'll sometimes get x-rays, MRIs, we look at functional evidence, how are you using your body, we'll look at the symptoms, and we make a decision. Here are the pros and cons. If we leave it alone, the pro is we leave it alone, we work on things. The con is you may have to be patient, work on a few things, work with the therapist, go through frustration, etc. The pros of a surgery, well, we can do something structurally. So my simple answer to that question is, the day someone is ready for surgery is, if we're looking at it in the setting of osteoarthritis, let's start with the least invasive approaches, is if there is damage to one of these structures here, where there is a mechanical problem, right? What do I mean by mechanical problem? If I have a pebble in my shoe, I don't know any good way that I can do rehab to get a pebble out of my shoe. Every time I step on it, it's going to bother me. So if there is a structure that is out of position and in a spot where it, by that position, is causing a problem, we'll sometimes say, look, one option is to get it fixed. Here are the pros, here are the cons based on your situation. If we take that further down the line, let's say we get to a point where we have someone who's got a lot of wear in the knee. That lining, that cushion has worn down. When will somebody need a knee replacement? Generally speaking, my opinion is, when someone needs a knee replacement is when they can say, the pain and dysfunction in my life is to such a degree that I'm ready for a big operation. The x-rays and MRIs, they are one part of it. But as you know, we don't treat x-rays and MRIs, we treat people. And so it becomes what we call a shared decision-making process. So I tell everybody, I'm like the guy in the back of your car. I'm saying, hey, I think a left turn would be a good idea. I'm not going to grab the wheel and make it for you. I'm going to advise you. And what you want to understand is, what are the pros and cons of each direction?
I would have patients who have gone through your procedure and evaluation, and you've told them that they would be a candidate for knee replacement surgery, and for whatever reason, they would tell me that they're not ready. And is there any harm in waiting?
My answer or discussion with the patient would be, what are you willing to do? What are you willing to do to get the things that you need? Because from my perspective, it should rarely be about waiting. My opinion is, every day is a gift, right? Do you want to spend your life and take away the things that you love to do? I wouldn't want to recommend that. So generally, I don't tell people stop doing A, B, C, D, and E and just wait for something to happen. What I tell them is, to reiterate what I just mentioned. Work on the foundations that you need with a therapist or on your own. Figure out what are the problems and how things are not working and work on those. Along the way, if there are significant symptoms, we have other ways of helping those too. And we have injections that can improve symptoms. The medical standards don't favor heavy use of medications, so I try to avoid those. And the indication for some type of injection, and by that I mean cortisone, gel, blood products. Cortisone being an injection of an anesthetic and a corticosteroid that is anti-inflammatory. So if you remember those immune system cells I discussed earlier, you lower the amount of those in the system. What I would say about these type of treatments is I look at them like condiments. If I handed you a bucket of salt, you'd say, what do I do with this? This is not a meal. So when you're using those, the best way to use them is in a context. I'm doing a rehab program and I'm stuck. I'm an 8 out of 10. I'm hurting all the time. I need some help. Perfect spot. Let's do an injection. Let's see if we can get you down to a 1 to 2 out of 10. Have the therapist work with you and see if you can get over that hump so you make functional progress. My general perspective is when you can use injections to guide your progress, then you're not waiting. You are optimizing your progress. I'll very often ask somebody, what % of a normal need do you feel like you have? And for me, it gives me a good perspective on where they're at. What I'll sometimes hear is between visits, it may go from 50% to 60%. Okay, and you may say, well, that's not very much. And I say, but you had somebody that was 40% before that. So I often try to shine a light on the attainment of progress, right? Encourage even small steps. So if you are ever struggling with making progress, it's very tempting to want to make it all in one shot. I did therapy 4 times, it didn't help me, I don't like it. Okay, but if you're looking at a problem that has been years in the making, it would make sense to really work on that too. It is one of the biggest problems I see, even in my own world, to be critical of surgeons. When I went into practice, I didn't really understand what do therapists do. Why are you there? I used to think therapy was this magical land. You go in, if you don't come back doing better, we get to offer someone an operation, right? Now, when I talk to therapists and I look at how do you measure progress, it becomes very nuanced, and it's not a formula. And so my answer is, waiting is good, but active recovery is better.
Okay, well, we'll go on to the next step, which is patient has decided that they want to proceed with knee replacement surgery. So can you explain what happens during the course of total knee replacement surgery? With some other additional questions, has the procedure changed in recent years, and are there any advancements that are around the corner?
We talked about the indications, and so let's just say you and I are sitting, we decided to do a knee replacement. You say, hey, what is this about? Well, what we generally will do is, number one, we do a little bit of proactive checking the health, right? They see you, we look things over, and I tell people, go to see your primary doctor and ask them, what is the best version of myself I can be in before this operation? What are the things that you need to do? I'm always a proponent of lifestyle choice modifications, right? Active, exercise, nutrition, sleep, mindset. Those are all okay. We'll sometimes do, to answer your question, what is new? I wouldn't say these are new, but over the last 10 or 20 years, I use 3D modeling. So if you have a worn out knee, if you go to this model over here, so we'll do 3D modeling, and we'll make a 3D model using an MRI of the knee. And then what we basically will do is we will virtually do the surgery on the knee, and that allows us to get some custom tools that we use in surgery. And then when it comes surgery time, most of these surgeries we're doing now as outpatients. Another new idea, which I'd say is still over the last 10 years or so, it's increasing. Most of the knee replacement surgeries we do now, people go home the same day. I'd say early in my career, and I'm not that old, We would keep people in the hospital 3 days, 4 days. And what's interesting is when we first began evolving to get people out earlier, it seems like it's not a good idea because you take someone who's just had this big operation and you're sending them home. But what happens when you get home? You have to go to the bathroom. You got to get up. You got to go get some food. You got to get up. What happens if you're in the hospital? You don't have to get up. You can just lay in bed for a couple of days. And here is a sobering statistic. You take somebody who's a little older and you put them in bed for a couple of days, you lose months of training if you've been training. So it is a rapid exponential decrease. So one of the new things that we do is we get people out of the hospital and we ask them to be active. We start therapy right away. When we do these surgeries technically, you come in, you get a general anesthetic. We have a few innovations in anesthesia that I don't want to bore you with, but we essentially make an incision over the knee, and it's about that big. And when we go into the knee, we'll make an incision down the front here. And then what we do then, and this is going to sound kind of gross, we move the kneecap over like that, right? Sorry. And then we bend the knee, and now we have access to it. And then we essentially will, based on the plans we have, we will remove about 1 centimeter, which is about that much, of the outer lining. Someone who's going to get a knee replacement is not going to have nice looking cartilage. It's going to be very, very worn. And so we then remove that, and we remove this, about 1 centimeter of that, and then we put something in that looks a little bit like this. And if you look at the difference, if you look at it from the side, there is not a lot that's taken out. Right? So we're only taking out a small amount, and based on the planning, what we take out, we want to try to put in the same thickness when we're doing this. Because the idea is we want to have just the right amount of space filling. We don't want it too loose, we don't want it too tight. We want it just right. And so it's called resurfacing. And there have been some changes in the metal and in the plastic over the years. So the types of plastic that we use now are tested in biomechanical laboratories, and they are found to have millions of cycles of testing. So if you go to some of these centers that are the producers, you will see in the lab it looks like something out of a high-tech movie. All these little robotic knees with these, and they're testing how much do these things wear, and there are millions and millions of cycles. So essentially we replace this femur part, we replace this tibia part, and if you notice we have metal on the femur, and then we have metal on this is called the tibia, and then we have this plastic liner in between. And we try to put it in there so we have just the right amount of tension. We usually will remove these ligaments on the inside. We leave the ones on the outside. And what you don't see on the model is we put a little piece of plastic on the back of this kneecap as well. And then we put it all back. We close it all up. We have to go through the kneecap mechanism, which is what I demonstrated on this model. And then we get you to start moving right away. The innovations that I see coming, a lot of them have to do with how do you improve the recovery. Can you get people to recover faster? We are trying to go faster and faster and faster. And any of you who've had one or know someone who's had one, we're seeing, and even in my own practice, I've had patients who are hiking in the mountains 4 weeks later. I've had physicians and therapists who are back to work, full unrestricted activities in just a few weeks. And so what we're really seeing now, because the technology is actually quite good. Another question I often get asked is, well, how long do these last? And the answer is, it depends. Like many questions. What are you going to do with it? What was your situation before? If we want to rest on some of the statistics, there was a study down out of the United Kingdom, looked at, we call them knee registries, and they looked down the line. And if you look at the 15 to 20 year survivorship, that means you put a knee replacement in, after 20 years, how many of those people still had the knee in? 95 to 98%. Very good numbers, right? Even with partial knee replacements, we didn't talk about very much, still 80s to 90%. It's still pretty high. So generally speaking, we don't see these things wear out very quickly. And so ultimately, the only time I would be concerned is if somebody said, I'm a stunt man, stunt woman. I got to jump on this thing over and over and over again. In that situation, I would try not to do a knee replacement anyway.
Are there any other restrictions in people that have had knee replacements?
It's a great question. And if you asked me that 10 years ago, I think my answer would be different. And it is one of the things that has caused me to change my own perspective is there are many things that physicians will say that are a habit and an opinion. When I looked for what are the facts to support how can I advise someone of this, I couldn't find any facts that would have me say you should not do A, B, C, D, or E. I couldn't find them. I was looking for them. What I saw a lot of is surgeons say, well, you shouldn't kneel. You shouldn't play basketball. You shouldn't play football. And I'd ask them, well, what's your reasoning behind saying that? I couldn't come up with an answer that was based on science. So what I tell people now is, depending on what you want to do, knee replacements were not made for heavy impact. That's not why they were devised. You go back the 60s and 70s where the genesis of these came out, they weren't made for that. So in an ideal world, we wouldn't want to do this in someone who is going to engage in collision sports. Unlikely. But I have an 80-year-old ski jumper, so it happens. So we try to avoid any type of heavy impact, but other than that, I don't place any restrictions. And I think many of these have come about. Many of us have loosened our hold on that too, because what we find is that if you tell an 80-year-old farmer in Iowa who's still making a living from baling hay, you can't do A, B, C, D, or E, what are they going to do? Are they going to re-listen? No, they're not. They're going to go about doing what they're going to do. And when you see someone, you see they're actually doing quite successful. And they're doing very, very, very well. I think all of us have taken a step back and said, hey, maybe we should really go a little looser on some of these restrictions. So I generally don't have them.
Great. A lot of people are concerned about how much pain am I going to have after surgery?
Yeah, great question. And I look at this in a way where I'd rather have someone over-prepared. So I don't tell somebody, oh, it's nothing. It's no big deal. What I tell them is there's probably going to be a moment where you tell yourself, why did I want to do this? Because if you heard what I just said, and you're cutting through muscle, moving things over, you're sawing pieces of bone off. If you take about 10 seconds and go on YouTube, you will never have a knee replacement. And so it is a considerable amount of pain. However, I told you we have a very modern techniques of how we control pain. I care about my patients having pain. We don't want them to have pain. But at the same time, part of it is unavoidable. So the current way we deal with this is we use a lot of different pain medications initially, and we call that a multimodal pain regimen. So rather than just putting so much medication that makes you unconscious, what we do is we have many different medications so that you can get through the first day or two. And then as they all fade away, you have a chance to see how it's going. And then you can move forward from there. So I would say it's a considerable amount. At the very first day or two or three, someone may be rethinking things, but I often find within a few weeks, they often are seeing, here are the results of this operation.
What would you tell patients in terms of what can I expect in terms of the total time of recovery from surgery?
Somebody who is a dutiful CEO who has been exercising and paying attention to their health through their lives, I would say very fast. I have seen people who have had substantial recoveries within 6 to 12 weeks, where they're going back to significant activities. What I see the most is it probably takes in the range of 4 to 6 months to really get an idea of, hey, where am I going? Most people, and I'm giving you an anecdotal answer. Most people will know within the first few weeks. I've had people days later say, wow, this feels completely different. But I'd say most people within a few weeks will say, this feels different. And it's because if you consider what I said at the beginning, there are nerves in the bone. And once you now replace that with metal and plastic, there are no nerves in metal, no nerves in plastic. So you're creating this artificial buffer in between the two. So when you're putting weight on it, you're actually loading this. And sometimes you'll get some pain around the bone edges, but generally speaking, once that operative, we've cut through this bone, pain starts to go down, pain will begin to subside.
Do you have an age limit in terms of who you will operate on?
So I'll answer this by saying I would take a 1965 Aston Martin over a broken down Porsche 911 Turbo any day, right? So I talk to anesthesiologists a lot about this. What I care about the most is, when all is said and done, is my patient going to be thriving? Are they going to be vital? Are they going to be able to do the things that they want? So that means we have to look at everything. And so I'll very often ask patients, how are you doing before? So somebody who is doing really, really well before, I wouldn't worry so much about. Someone who has got a lot of health issues, I would worry about more. So for me, it's less about the age. It's not to say I'm running around and asking 90-year-olds to have knee replacements, but it all really depends on how they are. I've had 90-year-olds we've done knee replacements on, but it's not without many conversations. Right. A 90, let's just say 75, 80-year-old who is walking well, who's got good trunk control, who has arthritis that has affected their daily life, not a lot of medical problems, that person is a better candidate than someone who is, let's say, 60, 55, who has a lot of health issues. So for me, it's less age dependent and more health and function dependent.
How often do you see complications from the surgery, infection, wound infection, that kind of thing?
Yeah, I would love to tell you never. And all of you would know I'd be telling you a lie if I said that. So generally speaking, it's very rare. Because if we do our due diligence, as I mentioned, if we really kind of choose carefully and everyone involved is aware of the pros and cons, it's very rare, thankfully. With that said, if you look at the statistics, the infection risk is probably below 1 in 1,000, so it's pretty low. Right? One of the most common complications we see after knee replacements is stiffness. We put it in, everything looks perfect. It's now 8 weeks later. I can't bend my knee all the way. I can't straighten out all the way. Why is that? Generally speaking, when you do a knee replacement, you bleed inside the knee because you cut the bone. If you start moving right away, then you can get the movement and you can get the bending, and you very rarely have issues. What happens is people are hurting, they don't want to move. The therapist wants to be nice, they don't push the person, and the body is just doing what it needs to do. Remember, I told you the body forms a scar, whether you're ready or not. So now you stiffen up in this position. And that may be the biggest complication, is stiffness. And we can see that depending on the situation, sometimes 5 to 10%, not a small number, a bigger number. Now the good news is most of the time when I strongly encourage patients, strongly encourage therapists, you got to get this, otherwise you're looking at another operation, we'll usually see progress in about 75%. So a smaller percentage will sometimes even go on to need another operation. There are medical issues too. Those are probably the top two specific orthopedic kind of complications. We'll often see other issues that are the direct result of the surgery stimulation, one of them being blood clots. What makes blood clot? Well, there are 3 factors. One is trauma. I make a cut in the skin. You have now, as I mentioned before, you trigger the body's cascade. That's one. Number 2 is lack of mobility. I'm laying in bed for 4 days, my blood starts to clot, I'm not moving, it now forms a nice clot. These can sometimes be life-threatening. And then the third issue, which is hardest one to predict, is some people have a predisposition to clotting. Sometimes they're health issues. So again, what does that go back to? Move, 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 move. All of these are pointing to get your motion early and keep moving. Other complications as well too, and nobody ever likes to hear these, heart attacks, strokes, right? And how do you prevent those? The things I told you. Look at things ahead of time, keep an eye on things, keep moving, watch what you're doing, make sure health issues are reasonably controlled.
We're going to now turn it over to questions from the audience.
Can you talk a little bit about a partial knee replacement, as a patella replacement. How does that differ?
There are 3 compartments of the knee. And so we call this the medial compartment. That's the one on the inside of the knee. And then we have the lateral compartment on the outside of the knee. And as you mentioned, we have the patellofemoral compartment. That's the kneecap. Those procedures are much less common than a knee replacement because, for the most part, when someone develops joint wear, it tends to be everywhere. So it's uncommon for someone to have it in just one spot. But with that said, there is an indication, and that indication is when we can prove that the lining is in one spot. And so we can use x-rays, we can use MRIs to really clarify where is the damage. And there's often, for me, there are a lot of questions. Are you sure it's the one spot? Are you sure it's not anywhere else? Because we want to make the right decision. So the thinking process going in is the pro and con is, if someone is ready for an operation, we talk about if we just do one side. When you're doing a patellofemoral replacement, you are making an open incision, you're turning the kneecap over, but you're putting plastic behind the kneecap, and you're putting, this is not a perfect replacement, you're putting metal on this area here, and the metal looks a lot like this here, it's just smaller. And so you're leaving these other 2, we call them compartments, we're leaving them intact. So the pro of that is you're not taking out all the different parts of the knee. The con of that is if later on you go on to have problems with those compartments, you may now say, well, why didn't I just do all of it at once? It's less invasive, it takes less time, the complications are a bit less. The issues are the survivability is a little bit less than a knee replacement. And I think it's because when you put something inside, there's going to be a little less stability if it's just one part of it than if it's the whole thing. If you look at the seating of this, if I put something right here, it is a little bit smaller of a foothold than that. Look, this is the entire, what we call condyle. It's very well seated. So the survivability is in the 80s and 90s, which means that 15 years later, we'll see the numbers a little bit less. So we see partial knee replacements in one compartment more common. And in those, we'll put a metal replacement on one end, and we'll put plastic below that with metal below that too. And I've generally found those can also do very, very well in someone that we can prove only has damage in that one compartment. So there is a very specific indication for it, but it is less common than getting a complete knee. Somebody who comes and sees me and says, look, I've been doing therapy for years. My health is good. I have severe arthritis. I've had injections before. I'm not able to do the things that I really desire to do. I'm ready for something bigger. That's someone who's ready to talk about this.
If a patient decides they don't want to do a knee replacement, you mentioned the use of corticosteroid injections, and are there other options that you consider?
Yes. And so part of my role is to help people work within their own desires. So we talked about therapy, and we talked about what a therapy plan can offer. So I would say that might be the keystone. Can we train the body to work in a mechanically efficient way? And my general experience has been that people will give up before they should. And a lot of it is motivation-based, because we all want progress quickly. So one, I'll try to help them get there. There are corticosteroid injections that I would say would probably be a first line. These are quick fixes, temporary solutions, but they can help with progress. There are gel injections, many of you may have heard of, hyaluronic acid. They function, and they're organic products, and they function by improving lubrication, lowering inflammation. The problem is because of our immune system, because they're made of organic substances, the body will recognize it and chew it up. So many of these are given in weekly doses for 3 weeks. There is a new horizon, which is the role of blood products. We hear about PRP, stem cells, things like that too. For any of you who are interested, I recently gave a talk on this too. I can give you the link when we're done here. Those have shown to some degree even greater promise than the two that I mentioned before. And to make things even more interesting, there has been some new data on the use of platelet-rich plasma with the gel. Now, what is platelet-rich plasma? In platelet-rich plasma, we take some of my blood, you do it in the office, we take that blood, we put it in a little tube, we spin it around, and we take that part of it that has what we call platelets. Now, platelets make blood clot, but it turns out that when you spin them around, you poke them, and when you activate them, they release all of these anti-inflammatory proteins, which it turns out, when you squirt them in a knee, once a week for 3 weeks, which is again the combination that has been studied, the outcomes are turning out to be better than using gel and or corticosteroid, and certainly better than placebo. And as I mentioned, doubling that up with the gels, we're seeing newer evidence might even be better than that. And when I say better, what I'm referring to is symptomatic outcomes. We do this to your knee, you fill out a little questionnaire a year later, 2 years later, how are you doing? We're seeing outcomes improving. There's a vast wasteland of products that are out there. And I am constantly being asked, should I use this gel? Should I use that gel? Should I use this product? There's a thing I wrap around my knee, it's electrical stimulation, it's ultrasound. There are many, many, many products out there. And I would say here is the rule I would throw out at you. If you're looking at one of those things, then ask yourself, is there any chance this tool is going to harm me? And for most of those, I'd say the answer is no. If you wrap something around you and you have electrical stimulation, I'd say the risk of it harming you is probably zero, unless you have a pacemaker or something like that. And so the question is it going to help you? If it's maybe, and the cost is not too bad, I say go for it. So as long as it's not going to hinder you, the one thing that I have a concern about is when someone uses products that make the knee stop moving. I'm going to wrap my knee in a splint and keep it there because it makes my knee feel better. I would say comfort and function are opposite directions. If you are going to do that, you're going to lose function. So there are many products that are out there, but I would recommend somebody work with a therapist, make progress, consider the use of injections from time to time.
It sounded to me like you were not a big fan of partial knee replacements. But if you're going to go that far, maybe you're better served just to do a complete total knee replacement. Did I read you incorrectly?
The indications are less. So I'm a little more cautious when we're doing partial knee replacements because I want to make sure we make the right decision. So I am a proponent of partial knee replacements in the right settings. Someone who is the perfect candidate is someone who is thin with a straight knee with one compartment damage. That person generally, if I can demonstrate they don't have a lot of wear in the knee, and these are people I will sometimes actually do MRIs to confirm that the damage is okay. Someone in that situation will often do extremely well. So I am a proponent of them. I find that sometimes when we start looking, even though many of us have pain in just one location, often you see a fair amount of damage elsewhere. And what happens is when someone has, let's say, kneecap and pain on the inside, many people I've noticed will limit their activities. So you limit their activities, and now we put in a partial, and now you increase your activities, and that other area that was worn out, that wasn't hurting, now starts to hurt. And that's why we have a conversation. Hey, you've got this wear behind the kneecap. It's not so bad. It's not hurting you. Are you sure it's not hurting you? And it's a judgment call. And that's the reason why. Because I think one-sided disease is very uncommon.
The anesthetic part. So some people get this spinal block, and a light anesthetic, and others get a full-blown, go-deep anesthetic, which I understand can be harmful for older people.
Yes, are you asking what is the recommended type of anesthetic?
Yeah, I would actually like you to answer the question whether or not a deep anesthetic is harmful for older people, and then give us also your take on which we should have.
I think if my anesthesia colleagues were here, they might they might not agree with the idea of a deep anesthetic, because they often say they have a compendium of tools that they use for various purposes. Now, with that said, I will usually rely on my colleagues to determine the appropriate fit. However, what we do find is useful is, depending upon the patient, we'll often do a spinal anesthetic, and we use blocks. And we use blocks on almost everyone. And what we also do is we dilute a combination of anesthetic with anti-inflammatories. And when we're doing this, and when I have the knee, you don't have to go to this, but when the knee is open, we'll take an injection and we'll inject all around or near the bone and the tissues everywhere, so that on top of whatever we have, I have about an 8 to 12 hour agent on top of that. And that helps people get better as well too. So we throw a lot of things in the mix to help people get active again.